Thank you very much, Schumann. I think that we will continue in the course of having sufficient time. Thank you very much indeed. We are now actually on time, I think, and it is indeed my pleasure to invite the next speaker to the podium, Antonio Pellicer. And as you know, he's the founder of EV, he is the chief editor of Fertility and Sterility, and I can think of nobody else being better than addressing us on how the future of IVF will be, and it is indeed my pleasure to see you here. The floor is yours.
Thank you, Klaus, for your nice words and introduction. Here is. Before I forget, I would like to invite you to our meeting in April in Palma de Mallorca, because I had this slide before this morning, but I forgot it. So it will be in April. I guess that you all know about Palma de Mallorca. It's a beautiful island in Spain, and we have prepared for you a fantastic meeting. So when I was asked to talk about the future, instead of telling you how it's going to be the lab, if it's going to be automatic, if all the embryos will be selected or not, I wanted to fix my attention on a particular problem, is the problem that we are going to face in this century. And which is the fact that while in the 20th century, that was the century of population growth after the 2 world wars, the 21st century is going to be the century in which the population is being old. In fact, in 2050, you see how about 30% of the population will be 65 years of age or more. And today, because we are basically in 2019, today there is more older people than babies under 5 years of age. And you see how the curves have been crossing, and this is where we stand today. So here is what we are getting for the future. And this is the main problem that we have to address in IVF as well. Because as we all know, the world's population has been affected because our lifespan has been increased. We have better health systems, but the decrease in fertility. So this is the real challenge that we have for the future. And we have to start to fight right now. And in fact, many of us are already fighting for it. And this is especially concerning in some countries, like in my country, like in Spain. If you see, these are data from the United Nations, and this is the mean age at first birth. And you can see here, for example, Spain is number 1 or number 2 in the list, together with Germany. So, and for data from Eurostat show you exactly the same. So women decide to have children very late, and this is increasing. So this is a problem that we are not going to stop, that has many reasons that we don't have time to address, but this is what is happening. And we know when we analyze, for example, the embryos of these patients with age, the percentage of unemployed embryos is increasing. So this is a message that we all know. So we have to, in the near future, and today we have, our main problem is age. And how can we fight against age? And as I told you this morning, this is a full program that we are developing in our different labs. Some people work trying to fight against the effects on the cells, cellular repair. Some others are trying to get oocytes, new or more follicles and more oocytes. And some others are trying to understand how can we prevent all these problems. So in the end, either we prevent follicular loss or we have to do something to increase follicular numbers. This is the message. So what do we have today? Today, we have successful programs of oocyte vitrification. And we use them all the time since 2007, 2008. And we do a lot of fertility preservation for non-medical reasons, also called, probably wrongly, social freezing. But in any event, here you have data until 2017, and social is in red. You can see how we have been doing social freezing for non-medical reasons in our population in Spain. So it's a lot of women. Now, if you see the age of these patients and you distribute in the number of individuals by age, you see how we are freezing at our own age. We are freezing the eggs between 36 or 35, 39 years of age. And we know that at that time, the quality of the eggs is not as good as it should be. They are not bad, but when we really look for pregnancies in these patients who have frozen eggs for social reasons, and we compare the outcomes with the gold standard, which in our case could be oocyte donation, here is the outcome that we can expect of oocyte donation. So the survival is about 93% of eggs from a young woman, and the pregnancy rate per transfer is about 45%. Now, if we look what has happened in our patients, these numbers might not be updated, they might be 1 year old, but they illustrate clearly how survival is lower, pregnancy rate is lower. Why? Because we are not freezing at the right age. So in the end, it's important, and this has been published, and you can go into the details 3 years ago, depending on the number of eggs that we are able to freeze, we can offer a prognosis for birth rate. Basically, if we freeze 12 eggs, it's about 40%, and goes up to 70 if we freeze 15, to 78 or 76 if we freeze 20, and basically to 97 if we freeze 40 eggs, which is very strange. That doesn't happen very often. So the second concept is also very interesting. Instead of allowing women to lose follicles, let's work in trying to avoid that these follicles are lost. And when women arrive to the age of 40, they might have more follicles than they should be if nature was working. And we are working in this project also. There's a group of us who is doing beautiful experiments in animals. And the first idea came from this paper that was published last year in PNAS. And basically what the authors did, it was to use anti-Mullerian hormone. And they, after giving anti-Mullerian hormone or saline to the animals, they treated them with chemotherapy. As I showed you this morning, the model of using chemotherapy in animals is the best model for premature ovarian failure, because you get rid of all the follicles. And using anti-Mullerian hormone, they were able to reverse the follicular loss due to chemotherapy. So basically here you have the number of follicles in the control with saline, and here you have the effects of chemotherapy. You see how you lose all of them, and using simultaneously with the chemotherapy anti-Mullerian hormone, you reverse to some extent the effects of chemotherapy. And this is a very interesting concept, because today we are using oral contraceptive pills for contraception, and women are losing follicles, and perhaps in the future we will lose a different compound that may include AMH or other proteins that not only prevents ovulation but also allows the maintenance of the number of follicles within the ovary. And when the women get older, we don't have that problem. And we have a similar experience with LH. And you would say, what is LH doing? If you give to the animals LH, here you have the number of follicles quiescent of growing follicles, and you give to the animals chemotherapy. Chemotherapy destroys most of the follicles, as you see, of the primordial follicles. And if you give simultaneously with chemotherapy LH, you restore the population of follicles. So these are experiments that, again, I'm presenting you something that has been already presented, at least in the format of abstracts, and we have many, many more experiments already done. But this is a promising field, because it's prevention and not intervention. So how about intervention? About intervention, I mentioned to you this morning about ASCOT, and I will take now a few minutes to explain you about our experience with ovarian fragmentation that Dr. Fatemi just made the perfect introduction. So the concept, again, remember, is the fact that even a menopausal woman has some, at least at the beginning of her menopause, she has some resting follicles inside the ovaries. We know that. And the question is if we can make these follicles grow. So there was an initial paper by Kawamura and Aaron Shue working together in Stanford. They showed that they were able to make these resting follicles grow. And the whole thing, as Fatemi mentioned, was about the fact that making small pieces out of biopsy of the ovary may change the predisposition of the actin filaments, and this may break this pathway, which in turn is very important for activation of transcription factors that increase pro-cellular growth and or anti-apoptotic genes that in the end will increase follicular growth. So all this basic works in two words: is you cut the ovary, you get follicular growth. Whether it's all this true or is an inflammatory response of the ovary is a good question that Dr. Fatemi asked. Inflammation is probably the answer, but the truth is that initially they had 27 women and they cut the ovary in small pieces, which was cultured for a few days, and after a few days they did a second surgery to put the ovaries in place. And out of these 27 women, they observed by ultrasound follicular dynamics, follicular growth in some patients. One of them was continuously ovulating and had a baby. So when I saw this, I firmly believe in that work. And it was because at that time, we were doing a lot of work in fertility preservation. And Cesar Diaz was coming to my office every time that he did a transplantation of the ovary into a woman when she was cured of cancer. And she said, listen, I get better results when I put the ovary back in small pieces as compared to the whole ovary. And I told Cesar, listen, Cesar, you have to do more surgeries. I don't believe you. Try again. There is something wrong. And he was not wrong. He was doing the same that the Japanese was doing here. But we didn't know why, but we found the answer to that. So once we started to do this, we also learned from the Japanese that it is very important the time between menopause and the surgery, which is not easy to identify, because many people start with, many women start with irregularities, with menstrual irregularities, and the doctor puts them under pills. So you never know when the menopause came, because they are already having artificial cycles. But in any event, it is better if you perform the surgery 1 year after menopause as compared to 5 or 7 years, because here is where you can find follicles and growth. The results of the Japanese were updated a year ago when we had our meeting in Bilbao, and we invited Kawamura, and he presented his results. Probably he has operated today twice as much patients. But the truth is that he had operated at that time 116 women, and he had 6 pregnancies. So this is about 6% or 6% pregnancy rate or less. So it's not that much. So we made some changes in the technique. We made some changes in the technique for 2 main reasons. Number one, because our experience doing surgery in women with cancer, in which we did the relocation of the ovarian cortex, showed us that just removing the ovary, cutting it into pieces and putting it back in the anatomic site in one single surgery worked. And also because the co-culture with these AKT stimulators, who are supposed to have some pro-cancerogenic effects, first of all, you don't want to listen about cancer, and second, it obliges you to perform a second surgery. So we changed the methodology, and this is why we changed the name. But it's obvious that our work is based on the Japanese, and they deserve the merit to be the first to perform these techniques. So then we wanted to understand whether it works in our patients with low ovarian reserve. And we started a randomized clinical trial that was registered and that is finished, is in preparation for publication, but basically women were underwent either surgery, OFA, or after surgery IVF, or directly they went to IVF. They were obviously low responder patients according to the criteria that Dr. Fatemi just mentioned to you. And the bottom line of the study is that we were able to screen 377 patients. We randomized 35 of these patients, and the message here is number of follicles obtained was not different, number of oocytes obtained was not different, clinical pregnancy rates, ongoing pregnancy rates, implantation rate in these low responders was not different. So we did not see any help of OFA in poor responder patients. But in our selection process, out of these 377 patients, we identify a few patients who had true menopause. And we analyzed them, we did the surgery and analyzed them as a separate group. They have not control because they were not part of the randomization. But these patients are particularly interesting. They are less, but they are particularly interesting. And first of all, out of the 24 women that we identified and we operated, there were 2 groups. Those who had true POI with amenorrhea and elevated serum FSH. And some of them, 8 of them, had what we call fluctuating and in the past it was called occult POI. That means that sometimes these patients bleeded, or that serum FSH were fluctuating and sometimes were lower than 20 or around 20, but not over 40. So therefore we have, let's say, the true POI and the fluctuating POI. So, and we did the surgery in these patients. And we did until May. Now we have operated more, and in fact we have already 6 pregnancies. But until May that I collected the data, we had 5 pregnancies out of 24 women in whom we did 28 IVF cycles. And in accumulation of the cycles, we had all these pregnancies. But what is interesting is that when we looked at women who had complete or true POI, the pregnancy rate was very low, like the Japanese. However, in the fluctuating POI, pregnancy rate is about 50%. So today, we perform OFA, especially if it's a young woman less than 38, and preferably if they have fluctuating POI and menopause for less than 2 years. And you may say, yes, but you don't have controls, and you're right. We don't have controls, and the number of patients is low. So because this is something that we are learning with time, I'm presenting to you what we know today. Maybe next year I give you a different message. But the truth is that when you look at to fluctuating POI, you see how in the whole population of women with POI, and we are talking about groups like a group in Paris, which collects all the POIs from the entire France, so they have a lot of patients, and you see the incidence is about 23–24%, and the incidence of spontaneous pregnancies is 17%. So doing the surgery, and although we didn't have controls, and although there were only 8 patients, but today we are about a pregnancy rate of 50%, which is more than what is expected from the experience of people who have many, many patients. However, in true POI, you may have some pregnancies, but it is around the proportion that we get and the Japanese get doing the surgery. And as I told you, this is what we are doing today. We are working for the future. The problem of facing and trying to fight against aging is that there are many, many factors, many hallmarks of aging. We work on different parts of it. Juancho García Velasco is working in Madrid very hard about telomere length. We also work in DNA repair. So we work in different ways of aging, but so there are so many things to address that it will take time to solve the problems of aging and its relationship to reproduction. But certainly, if you ask me today, Dr. Fatemi asked me, what do you think about the future? The future, especially for those of you who are involved in research as well as clinic, you should have potent teams, groups of scientists and clinicians working in reversing the effects of aging. And I finish my presentation just showing the names of the very many people who are involved in this project, because as you can see, it's a huge project, very ambitious. I don't know where we will arrive, but we will do our best. Thank you very much for your attention.